Good morning, everyone. I hope everyone is doing well. I'm Dr. Amber Khan. I am the chair of the IMANA Education Committee. And this morning, we have a very special webinar. I'm proud to share a collaboration with experts in the field of bone marrow transplants. Beginning, we will have Dr. Ayman Saad. He is the professor of internal medicine in the Division of Hematology at the James Cancer Hospital Solove Research Institute. And this morning, he will be presenting the understanding of bone marrow transplant, the process, the side effects, the recovery, and what to expect. Additionally, to shed light on why diversity is essential to the National Bone Marrow Donor Pool, we have Mr. Mark Dotson this morning. He is the clinical operations partner at Columbus, Ohio, and he is from the Be the Match Foundation. Mr. Dotson will discuss the need to increase the ethnic background of the donor registry and how to help patients find their life-saving bone marrow donor to treat their blood cancer for disorder. Thank you so much, gentlemen, for being here this morning. And Dr. Saad, whenever you are ready, go ahead and take the floor. Thank you.
Thank you. Okay, so I'm going to start here, just starting with terminology, because these are terms that you may hear if you read about the stem cell transplantation, bone marrow transplantation. To the word hematopoietic means the tissues that forms blood cells, which is basically the bone marrow. Stem cells are the primary source of blood cells renewal, because all of our blood cells, they have a lifespan, and eventually they die off and they have to be renewed. So there is a small pool of stem cells which represent less than 0.1% of all bone marrow population. These basically renew all the stem cells of the blood cells. The stem cells are naturally found in the bone marrow. As I said, they can also be mobilized or moved to the peripheral blood if the person has growth factor injections. They can also naturally be found in the umbilical cord blood, and that's basically the blood in the umbilical cord when the fetus that you see when the fetus is born. So when you see hematopoietic cell transplantation, that's a broad term that we use to describe either bone marrow transplantation using a bone marrow as a source for a stem cell, or using peripheral blood as a source of stem cell. We call it PBSC, or peripheral blood stem cell, or umbilical cord transplant can be also be a source for stem cell transplantation for patients who need this kind of therapy. Transplantation in our clinical field is divided broadly into what we call allogeneic, meaning that you use a donor source, or autologous, meaning that you use the patient's own stem cell. The purpose of the two procedures are completely different. With the autologous transplantation, the purpose here is to help recovery of the patients after giving high-dose chemotherapy. But what I'm going to focus on today is what is really transplant is when we get a foreign or a donor-derived stem cell from a donor and use it for a patient. That's what we call allogenic transplantation. So when do we need to do this? We do this if the patient has basically cancer in the bone marrow, what we call neoplastic process in the hematopoietic tissue. Or this hematopoietic tissue or bone marrow tissue could be defective. And this could be something that the patient was born with, or something that was acquired later on for different reasons, including genetics, chemicals, environmental hazards. So again, going here to the indication of allogenic transplantation, people who are diagnosed with malignant disease, cancer like leukemia, either acute or chronic, lymphoma, multiple myeloma, these are in the box of the malignant diseases. And again, it could be non-malignant diseases that you will hear about, aplastic anemia, bone marrow failure syndrome, sickle cell, different immunodeficiency disorders. So how do we collect or harvest the stem cell? There are two general ways to collect this. If we're going to use a bone marrow harvest, the donor actually goes to the OR, and this is just a one-day procedure. The donor goes home on the same day. The procedure takes 2 to 2.5 hours maximum. It's done under general anesthesia. There is no medication that the patient needs to take beforehand. The only thing that may happen is the patient may need some pain medication afterwards. But it's a one-day procedure. Patient goes home on the same day. Contrary to this is stem cell collection on the peripheral blood. In that case, the donor receives daily injections for 4 days. He's hooked to a machine similar to dialysis machine, and this machine basically takes the blood, filters the stem cell out, and infuse the blood back to the patients. It's done as an outpatient procedure. It takes 1 day, typically maximum 2 days. Patient again goes home in the same day. This is preceded, as I said, by injections for 4 days of what we call growth factors. No anesthesia involved here. So how did this all start? I'm just going to give you a little bit about historical background here. The interest in studying radiation effect in human was sparked after the World War II and aftermath of the nuclear bombing. Unfortunately, this continued to be unmet need because the nuclear accidents is not only related to wars anymore, but can actually occur even in our civil life. And we've had at least 2 major nuclear accidents that have exposed the human to significant radiation since World War II. The work of Lane Jacobson at University of Chicago in the late 40s was actually very similar in understanding where the stem cells live in our body. In his work, actually, he exposed animals to lethal radiation, and he protected the spleen. And he discovered that mice with protected spleen or shielded spleen, they can recover their stem cell, they can recover their bone marrow function. So he basically hypothesized that the spleen is a site of the stem cells. And he had the same observation when he shielded the femurs. So again, implying that the stem cells are in the spleen and the bone marrow, which is in the big bones. And then 2 scientists in the University of Toronto in 1961, Dr. Macchiola and Dr. Tell, did another similar experiment when they infused bone marrow to lethally irradiated mice. And again, these mice were salvaged by infusion of the bone marrow. And when they looked at their spleen, they found these colonies that you can see as rounded balls here in the spleen, forming new hematopoietic or new blood-forming tissues. So that was, again, another proof that the bone marrow is a source of stem cells. This has brought to clinical use by the major work done by Dr. Donald Thomas. He was in the 50s. He was actually a physician in Cooperstown, New York. He was interested actually in studying radiation effect in leukemia. And then he said, well, if we can kill the leukemia, it's a blood cancer by radiation, why can't we just do this and follow this by bone marrow infusion? So perhaps we can save the lives of these patients. And he started to do a lot of work in animals and in human. He published one of his early papers in 1957 in New England Journal of Medicine, one of the most prestigious journals in medicine. And he describes the outcome of 6 patients with different malignancies treated with radiation and bone marrow infusion. So this was just the beginning. 33 years later, Donald Thomas was awarded Nobel Prize in Medicine and Physiology for his work in stem cell transplantation. He got this award actually with Joseph Maury, who did the first kidney transplant in Boston, Massachusetts. Then obviously, this process at that time was a little bit a random process because you can infuse any bone marrow in any patients. But it wasn't until the 50s when 3 scientists independently described what we call tissue typing or tissue antigen. They described antibodies against foreign tissues. And that was the basis for tissue matching that we use nowadays when trying to identify a donor. After this, more clinical successes occurred. As you can see here in 1968, the first bone marrow transplantation was done for an infant who was 5 months old. He was suffering from a disorder called SCID. SCID is a severe combined immunodeficiency. It's a severe immunodeficiency disorder that the males are born with. He got his transplant from his sister in the University of Minnesota. Whom you see here is Dr. Robert Tugod in the University of Minnesota with Nixon in the White House, 1973, in recognition of his important work. Interestingly enough, this boy who was saved by this stem cell transplantation, he was the first one to survive in the family. There were 11 males in the same family who died of the same disease, unfortunately. After this, in the Fred Hutchinson Cancer Center, where Dr. Donald Thomas, they did the first successful, again, this is not the first, but this is the first successful sibling transplant in a patient with leukemia. This was 1969. Then, until that point, all what we were using was just a sibling, because this is when we discovered that the sibling can be a tissue match and the other paste match. And then in 1973, this was the first successful experiment using an unrelated donor who volunteered to be a donor for a patient who was also suffering from SCID, the same immunodeficiency disorder. And the patient was treated at Memorial Sloan Kettering Cancer Center in New York. And this donor actually was from Denmark, and this was in 1973. In 1979, Dr. Robert Graves, who was a veterinary doctor, his daughter was diagnosed with leukemia, and she relapsed. They were told that the only treatment for her was a stem cell transplantation. Unfortunately, there was no family match, and there was no prior track record using unrelated donor or volunteer donor to treat leukemia. So Graves took his daughter, went to Fred Hutch, and they were willing to do the experiment. They wanted to do anything to save their daughter's life. So at that time, the platelet units are stored in the blood bank with tissue typing. And the reason for this is actually unrelated issue, but sometimes we have to use platelet infusion from a tissue matched donor. So they were able to look at the different tissue types of the platelet units stored in the blood bank and identified a blood bank employee who donated platelets, or who was willing, actually, who was in the donation list for platelets, and his HLA type or the tissue type was matching with Laura. And he agreed to donate stem cell for her. So this was the first unrelated volunteer donor for a case of leukemia. And this transplant was successful, and Laura actually survived after this transplant. Since then, the need for a volunteer unrelated donor was basically established, and Graves, Laura's father, took this actually to a higher level and started to advocate for establishment of HLA registry for bone marrow donors. And eventually, a national marrow donor program, NMDP registry, was founded in 1986. And this was a federal organization, later became a nonprofit organization, as you can see here. The first donor match using this registry was done in 1987. Here you can see the numbers of allogenic transplant coordinated by the NMDP, which is volunteer donors, since 1987 until 2020. So you can see it's combined over 100,000. That's basically volunteer adult donor. And here is the umbilical cord transplant. This graph shows the number of allogenic transplantation done annually, and you can see it's rising. What you see in blue here, this is the autologous transplant. So don't look at the blue, just look at the green, which is the allogenic transplant done over years. So you can see every year you get thousands of cases. As a matter of fact, like for example, here in 2018 was 9,000 transplants done in the United States. And this is the total number of allogenic transplants just in the US. This graph shows you the donor source at different age groups. So here's a young little ones and older patients, and this is the percentage of donor here. So you can see here, this is identical sibling, unrelated. This is the volunteer donor. This is the umbilical cord. And these are other related, which can be like mother, father. But if you just focus here, this is a volunteer donor source. You can see it's 40 to 50% of the donor pool across different age group. That's the only thing I just want to show you in this. So the process of the transplant, it's a sophisticated medical procedure, but not very highly complicated from the patient's perspective, or at least from the donor's perspective. So this is from the patient's side. The patient is admitted to a special room, what we call HEPA filtered room. This is like basically a room with sterile environment. Patient is admitted in the hospital for about 4 to 5 weeks. They receive chemotherapy, what we call conditioning regimen, and this followed by infusion of stem cells. Stem cells are infused very similar to infusion of blood products, as you can see here. Yeah, but we just use IV access for this infusion. And after this, the patient will have supportive care, and this supportive care will include several things. These are just examples, like patient may need blood transfusions, antibiotics to prevent infection, or sometimes we use this to treat infection if indeed happened. Immunosuppression medication will be needed to prevent a complication called the graft versus host disease. But this basically the big picture of the process from the patient's perspective. After the inpatient stay, the patient is discharged, it goes home and start to follow as an outpatient. When we see the patient as an outpatient, we monitor the blood counts, make sure that the blood counts remain stable, because this will be the sign for success of the transplant. We monitor if the disease comes back. Patients will be continued prophylactic antibiotics for a long time, and they will receive immunosuppression. As I said, they will continue in this to prevent GVHD. Generally, we don't continue this forever, like the solid organ transplant. The good thing about the stem cell transplantation is eventually patients can get off immunosuppression at 6 months post-transplant, and they can have basic normal life after this. About only maybe 30 to 40% of patients achieve this goal on time, but about 20 to 30% require longer immunosuppression. It can be 1 or 2 years, and occasionally they have to be in immunosuppression for several years. But the reason most patients don't require immunosuppression forever is the stem cell pool that we transplant has actually immune cells as well. So we are not only replacing the bone marrow, but replacing the immune cells as well. The allogenic stem transplantation can be curative for many diseases. Non-malignant diseases have a higher cure rate. So for example, aplastic anemia, 80 to 90% of patients can be cured by this process. Acute leukemia and lymphoma, you can cure more than half of them. Estimated about 60% of these patients can be cured with this procedure. The most sinistrous complication of the allogenic transplantation is graft versus host disease, which is known as GVHD. It happens in the majority of the patients. As I estimated here, about 50 to 70%, they suffer GVHD. But it's oftentimes mild and can be controlled by either topical steroid if the patient has a skin rash, or systemic steroid for short time, which could be 2 to 3 months. Only 10 to 20% they can have severe GVHD, and unfortunately, even that can be life-threatening complication. So clinical research is definitely ongoing on this regard, trying to mitigate the risk of GVHD and improve the chance of curing cancer with allogenic transplantation. This graph shows you the improvement in the survival after transplantation. So you can see here, these are the number of years after transplantation, and this is the percentage of survival. So, and here is a different time era. So between 2001, 2005, the survival was like this. So the lower is lower means lower survival, because basically here that at 3 years time point, you have only about a little bit less than 40% or 40% alive. But when you go to the next era, 2006, 2010, this has improved significantly, as you can see here. In this decade, 2011, 2017, you can see this went up to close to 60%. This is a statistical number implying that there is a real difference between these three eras. There are several keys for success, not only the procedure itself, but definitely patients need to have access to the procedure. Patients need to be motivated. Patients will need to have a caregiver who can take care of the patient the first few months of a transplant. There are several other factors, but I personally believe that main thing we cannot function without is a suitable donor. If you don't have a donor for this procedure, you won't have any of the above. I think this is probably the last slide I have. Yeah, and with this I conclude, and I'll let Mark go from there.
Thank you, Dr. Saad. Hello, everyone. Again, my name is Mark Dotson, and I work for the National Marrow Donor Program, better known as Be the Match. I want to thank you all for allowing me to come speak to you today. At Be the Match, our mission is pretty direct. We save lives through cellular therapy. But how we do that is where all of you can play a role. Be the Match is the world's largest and most diverse registry in the world. And that's because individuals like yourself are willing to step up and donate a life-saving product for a patient in need. So at Be the Match, really what our registry does is we provide a second chance at life. If you're a patient and you're diagnosed with a life-threatening disease, such as leukemia or sickle cell anemia, only about 30% of our patients have a fully matched donor within their family. The other 70% have to come to Be the Match registry to find that perfect match. As you can see, our registry has a global reach. We have over 22 million donors on our registry. Last year, we were able to impact 6,553 different lives. We handed out over $4.78 million in patient assistance. And not only that, we're involved in more than 200 different research studies trying to find different cures and therapies for our patients. As I said, last year we impacted 6,553 lives. 90% of these transplants came from adult donors, either PBSC or bone marrow. The other 10% came from cord blood. But the number that our organization really looks at is this 9,780 number. That's the number of patients that came to our registry and couldn't find a match. And the reason that almost 10,000 patients came to our registry and couldn't find a match is because matching's hard. Matching is really complex. It's based off HLA markings, which stand for human leukocyte antigen. You receive half of those from your mom and half of those from your dad. If you cannot find that perfect match within your family, you're going to turn to us. And what we know is that patients are most likely to find a match with a donor who shares their ethnic heritage. But currently, not all patients have an equal chance at finding a donor. As you can see, there is a huge disparity depending on your ethnic background of finding a match. If you're African American, you only have about a 23% chance of finding that match. Compared to if you're white, you have a 77% chance of finding a match. As an organization, this is our biggest goal moving forward, that no matter your ethnic background, when you come to our registry, you will be able to find that perfect match. And really the way we're going to do that is through our vision, equal outcomes for all. By the year 2023, we're going to double the number of lives saved in this underserved population. And how we're going to do that is by increasing awareness and education in these communities and talk to individuals about the real need of joining our registry. We currently have big initiatives going on in the Atlanta market, Chicago market, Houston market, and then Minneapolis, where our headquarters is at. We also work with the Center for International Bone Marrow Transplant Research on studies that really expand options for all of our patients. If you're sitting there and you're wondering how can you help, well, there's 3 easy ways. Number 1 is you can join our registry. This is going to take about 15 minutes of your time. If you are able to give financially, as I said, we handed out almost $5 million in patient assistance last year, and many of those patients would not have been able to make it to transplant without your help. And then finally, please engage our network. If you have social media, Twitter, Instagram, Facebook, tag us at Be The Match. I would assume many of you today might be hearing about Be The Match for the first time. So spreading the word of Be The Match and what our mission is a great way to become involved. As I said, it's really easy to join the registry. All you need to do is go to Google, type in Be The Match, join the registry. You'll click on that link. It's going to ask you a few questions. We will send you a swab kit in the mail. Once you receive it, you're going to swab both sides of your cheeks. You'll return that to us, and that's where we'll get your HLA typing into our system, and we'll add you to the registry. At that point, you'll get the chance to donate. You only have about a 1 in 430 chance that you'll actually be someone's life-saving match. And this is all completely free, by the way. A few of the questions that we receive is, am I eligible to join the registry? If you're between the ages of 18 to 44, it's completely free. If you're between the ages of 44 to 60, it's going to cost $100, and 60 is our cutoff age. And the reason for that is all the studies that we've seen, the younger the donor is, usually the better the outcomes the patient has. Not only that, we're going to make sure you meet health guidelines. As a registry, protecting our donors is one of the biggest things we do. Not only that, we want to make sure it's a high quality product for our patients. And finally, you have to be willing to donate to any patient. If you do join our registry, you have the chance to cure over 70 different diseases. These include things such as leukemia and lymphoma, sickle cell disease, severe aplastic anemia, and inherited immune disorders. As Doctor said earlier, there's 2 main donation methods, and that's going to be either peripheral blood or bone marrow. When you go in for a PBSC donation, we're going to stick a needle in one of your arms, take your blood through an apheresis machine, collect the cells that are needed for that donation, and then return the rest of the blood to your other arm. For a bone marrow donation, you will be put under anesthesia, and a physician will actually extract that bone marrow from your hip. And really, how each one is chosen, the patient's doctor chooses the best method for each patient. The third way you can donate is at birth. This is a completely painless process, obviously besides the birth. Otherwise, this product will be completely discarded, and it's going to be free unless it's for personal use. One of the other questions we get a lot is there any cost to saving a life? No, donation is completely free. You're obviously stepping up for another individual in a huge way and for our organization. If you do have to travel some distance to an apheresis center or collection center, Be The Match is going to cover all costs. Not only that, we are going to allow you to bring one companion with you so you don't have to go through this alone. Also, you will never see a medical bill. The medical costs are either going to be covered by the patient's insurance or Be The Match insurance. And at the end of the day, it doesn't take long to save a life. As I said, it's going to take about 15 minutes of your time to actually join the registry. The total donation process is going to take about 20 to 30 hours, but that's over a 4 to 6 week period. And most of that time is going to be on the actual day of donation. The other time is going to be in 30 to hour and a half increments throughout that 4 to 6 week period. Not only that, we really try to work around the donation process around your schedule. We know that donors have busy lives, so we try to work with you while also keeping that patient in mind. And here's the big question: does it hurt, and are there risks? While TVs and even the news widely exaggerate how scary bone marrow donation is, it's actually much less dramatic. Donors are given anesthesia during the procedure, so you're not going to feel any pain during the procedure. You might have a little discomfort during recovery, but this is going to vary from patient to patient, and those symptoms usually last a few days up to a week. Some of the side effects might include back pain, fatigue, headache, and bruising of the area. If you donate PBSC, donors maybe experience some headaches and body aches several days before the collection, because as the doctor said, you are going to get shots of filgrastim to get those cells activated to make sure we collect enough cells for our patient. But these symptoms usually disappear shortly after donation. And then finally, your body will replace all the marrow that you give us. And while no medical procedure is completely risk-free, every precaution is taken to ensure the safety and well-being of our donors. Trust and privacy is huge for our organization. Maintaining the public's trust is essential to everything we do. You're not going to have to worry about us ever sharing your information with any other company or any other organization. Even our transplant centers can't find out who you are. They actually search for you using what we call a DID, or donor identification number. And as I said, if you're fortunate enough to give to our great organization, this is where some of those funds might go. $25 is going to cover a copay visit for a patient. $100 is going to cover the cost of adding a potential donor to our registry. $300 can cover the cost of lost wages for a volunteer donor. But I'll tell you right now, 99% of those volunteer donors won't take a penny. Many of them have gone through transplant themselves, know a family member or a loved one that has gone through this, or really align with our mission. And then $500 will secure temporary housing for our patient and their caregiver near a transplant center. Not all transplant centers are in the backyard for each patient. Some will have to travel up to 5 to 8 hours. And at times, the physician's going to ask the patient to stay within a 60-mile radius of the transplant center for weeks, even to months on time. So this is one of the big needs of our organization for our patients. And finally, as I said, please spread the word. Share us on Twitter, Instagram, Facebook. If you have time this week, I would highly recommend going to YouTube and type in "Be the Match Donor Meeting First Time." It's going to give you a great idea of what our organization does and really who we are. Please tell your friends and family about Be the Match. If you're a part of an organization within your community that might align well with our message or would like to join the registry, I'm going to have my contact information at the end. Please feel free to reach out to me with any questions, or together we can make a life-saving impact. Thank you.
Thank you so much, Mr. Dotson and Dr. Saad. This was a very interesting discussion. So firstly, is in regards to just the entire history in regards to stem cells. For some people, the idea that it's innovative or that it's new, it was very interesting to hear the history behind it, because it seems like it's been around for a long time. The SCID case study with the child in particular, I believe you mentioned, was back in the 40s. And to go from a related individual to an unrelated was almost over 50 years ago. So that was quite fascinating. I think that some people have a hesitation with thinking that this is something that is fairly new, but it has been around for some time. And Mr. Dotson, you mentioned that only about 30% of the donor matches are from family. And so therefore, a majority come from someone unrelated, and your chances of finding someone who is a match to you is within your ethnicity. And I think that within our particular audience, for those who are of Asian descent or Arab descent or African descent, Mr. Dotson had shown a slide that really depicts the need to register, to be a donor, to help others in need, and from our religious perspective, that we do share the moral principle of helping those who are ill and thinking of others. So if you are interested in being a donor and registering, we will share the Be the Match website and information on our IMANA Education Committee website. We'll share the link. And if you don't feel like you are ready to take that step yet, then please consider offering a financial donation as well. We do have a couple of questions. Firstly, to Dr. Saad, you mentioned that the GVHD, that a majority of the patients deal with this. Do you, from your experience, do you notice that some patients avoid transplant because of this reason, because of this fear of the potential of the high potential of GVHD?
So many patients decide against transplant for several reasons, not just for GVHD. GVHD per se wouldn't be precluding cause or precluding factor to have a transplant, but they are sometimes worried about other toxicity, getting sick, because this can be pretty intensive therapy, in particular for certain population, people who are other medical illnesses. Like if someone has chronic uncontrolled heart failure, has chronic debilitating disease, these people don't do well with transplant and they don't tolerate the procedure very well. So bottom line is there are several other side effects of transplant. GVHD just happened to be the most striking one or the most prominent one. But I haven't seen a patient saying, I am not going to have a transplant because of GVHD, because as I said, it's only severe or life-threatening 10 to 20% of times. So it's not big percentage, in my opinion.
Okay. Some are asking for Mr. Dotson's contact information, which we will share with his permission on the website if you'd like to gain more personal information if you're interested in donating. Mr. Dotson, we had a question about if you match with a patient, will you get to find out patient updates? Will you get to meet your transplant recipient? What are you did briefly mention a little bit about the privacy conditions. Can you elaborate on that?
Yeah, that's a great question. So usually there's about a year time period where you can send letters to each other, but it can't have any identifying information. After that year time point, it's kind of up to both the patient and the donor to share that information with each other and get in contact with each other. So it's about a year time period that you have to wait.
I can elaborate a little bit on this, Amber. We have hosted actually some meeting between patients and donor in an institution that I worked in before, and probably in OSU, Ohio State, we've done this before. But as Mark said, after certain time lapse, they can meet in person. Before this, they exchange these messages through NMDP, so they don't have direct mailing contact, obviously.
Okay. Yeah, I noticed that some of the pictures that you had showed both the donor and the recipient, which really gives a nice face to, it personalizes the process very much. And, it's something in which I'm sure encourages others to donate as well when you get a chance to see someone in need. That being said, privacy is of the utmost importance as well. We did have another question in regards to the umbilical cord, and in terms of how that process works. So is that only with self-donation, or is that for others as well, or for relatives?
It usually, cord donation is either kind of two options. Either you keep it for your child or the siblings down the road, or it'll be added to our registry. If you'd like to add it to our registry, that is completely free. The cost is going to come where it's for more personal use. I do want to let people know that many hospitals don't actually provide this service of cord blood. There's only certain hospitals in each state that actually provides a service. So if you're interested in finding more information on that, my contact will be shared. So reach out to me and I can let you know which centers actually provide that service.
Also, what diseases can prevent you from being a donor? So that way you can be informed on, if you qualify to register.
So there are several diseases that some of them are absolute contraindication, others are relative, meaning they will need further medical assistance. So if someone has chronic infectious disease, such as hepatitis, HIV, these are typically excluded from donation because these diseases are transmittable by stem cell donation. But there are other diseases that we can work with. So, for example, if someone has autoimmune disease, rheumatoid arthritis, usually these people don't do well if we give them a growth factor shot and do peripheral blood mobilization. But we may be able to do a bone marrow harvest in the OR without the shots. So there will be some medical illnesses, and there will be other situations where we have to take precautions. If someone has a seizure and takes seizure medicine, we have to time the medication intake with the apheresis procedure to avoid any reduction in the seizure medicine level in the blood. So we can mark most of the time with the patient if they have a chronic illness or if they take certain medications to make sure that the process is not going to harm them.
That's really great. And it's, if someone is very interested in donating, but find out that they do not qualify or, that accommodations are not able to be met, then a financial donation is just as important. So to consider yourself capable in all aspects. We did have a follow-up question in regard to the umbilical cord, and that is that it's very common to see delayed cord clamping. Are either of you familiar with how that impacts being able to use the umbilical cord in the future with the benefits that have been found of delayed cord clamping? Has this been found to be the purpose of it, or what are your thoughts?
Yeah, I'm not sure if Mark can answer this because I cannot myself. So let me tell you, I learned from Mark that not every hospital has the capability to collect umbilical cord blood. So the hospital has to be equipped with guidelines and staff that is trained to collect the cord blood. So the procedure is not a random procedure. There is guidelines and there is a process for this. Okay, so many hospitals, they don't have this. They are not going to store the cord blood. Okay, so keep this in mind. So there is a process. I don't know personally if the delayed clamping is going to impact or not, but I'm sure the guidelines will definitely have an answer for this because it's a process. And one more thing I want to say about the personal use of the cord blood. Studies actually have shown that personal use of cord blood is extremely unlikely. So people who store the cord blood and pay monthly fees for this, only very small minority of patients will eventually use this for their kids. The general recommendation is against storing cord blood for personal use, unless someone really has passion to do this, or they have some illnesses in the family. There will be special situation that we need special counseling. But in general, I encourage people to store the cord blood for public use. If God forbids one day the little child or one of his or her siblings needs the cord blood unit may still be available in the bank, available for use for free. So there's just one point I just want to point out.
And I imagine that's very interesting. And I imagine that a lot of the questions in regards to the umbilical cord is because that is usually, at least from my own personal experience, and for those that I know, that's really the only time when, a patient is asked, a woman who is pregnant or about to deliver, when she is now being introduced about the idea of being a transplant, and having to think ahead. So it requires, other than that, then it requires moments like this where we have someone from a foundation who can come in and share the importance of donating, with the exception of, those particular instances, which is where I feel like most people in the public get that exposure. We'll have one last question, and this is kind of a question in regards to just in general about stem cells, and about, the future, as there's a lot of talk about stem cells in the news. What are your thoughts on, scientists and wanting to use stem cells, just outside of, even the spleen or the bone marrow, but just the benefits or the possibilities that stem cells can offer for those, within the medical field, or for even patients who are in need of a donor in regard to other diseases outside of these?
Yeah, there is a huge interest nowadays actually in regenerative medicine. And these basically are studies that are trying to utilize different stem cells, not hematopoietic, but other like nerve stem cells, to try to cure some chronic neurological disorders. So this is an expanding field. Unfortunately, there is nothing of clinical use right now, but there are several studies trying to use heart stem cell for patients who develop heart attack and they have an area of their heart that's dead, and they live with chronic heart dysfunction. There are several studies trying to infuse a stem cell for these patients, trying to regenerate the heart, regenerate a damaged nerve after an accident or after a disease. There is a huge interest in this area, and it's ongoing, but unfortunately there is nothing that's clinically usable right now at this point, as far as I know.
Well, thank you so much, both of you, for your time. I really personally benefited a lot from this talk. You really shed a lot of light on this topic that is really not discussed as much. I hope for those listening that you will consider donating. We will share the Be the Match website and any information in regards to how to register to donate or even offer financial donations. As Mr. Dotson mentioned, that the donation process is free. And so please do not hesitate, even from a financial perspective, to consider donating. If there are any other questions, we will set you up with contact information with the Be the Match. But thank you both so much for your time and for sharing your expertise this morning. We would look forward to having you back in the future if you are capable and willing. But thank you very much. And until the next webinar, we will talk with you all soon. Thank you very much.